All right. Hello, everyone. Thanks for joining the session. We'll try to make this fun and interactive. I'm Sarah Wahlster. I'm a neurointensivist at the University of Washington. And then Dr. Citerio needs no introduction. But
I'm Giuseppe Citerio from Italy. Good morning. Good afternoon.
And we'll just try to go with some real-life cases that we have seen in our ICUs. I'm sure many of you have seen, as you know, brain death is a very ethically challenging and complicated scenario. And I have to say, I get more white hair in my head, but still every case I have, there's always a kink or something where I have to ping someone. So we'll show some of those cases. Let's advance. Quick historical background. Going back to the Middle Ages, there was always this kind of like the mind defines us concept. One of my attendings told me that brain death is really an artifact of good ICU care, and that it's basically a side effect of it. And with ventilators evolving, but also with organ transplantation advancing, we were able to create the situation of brain death. First reports come from France and Germany in the late 1950s, and then the first criteria were the Harvard criteria. And I'll tell you those. It's interesting because it was coma, absence of brainstem apnea, but it was also flatline EEG and absent spinal reflexes. And so it's interesting. That definition has evolved many, many times over the years. Brain death became a legal concept, actually was discussed in religious in the 90s in the Vatican, and in many cases, and there were leaders coming together, standards for children were created. And they used to be different, but actually last year in the US, the first guideline that was joint adult and pediatrics was published. And there have been these AN practice parameter, and in 2020, and Dr. Citerio was a part of that, a big international group published a consensus. And the reason for that is even in your own city, if you went to different hospitals, every institution has their own protocol, and there's lots of practice variations worldwide. And it is because it should be a very straightforward concept, but there's always little kinks and challenges. And there's also differences in concept amongst the clinicians themselves.
May I add something?
Yeah. Sorry?
May I add something?
Yes, of course.
I think one of the important things that we did the World Brain Project is that there are a lot of variability here. Variability depends on laws, because there are also laws. But if you look at, there are a lot of papers that were in the direction of identify the difference. And I think it's the wrong way to go. Yeah. Because if we start to say that, I don't know, where are you from? From Spain. Where are you from? Greece. But in Spain and Greece, the same patient is judged dead by you and not dead by him. I think the population, the lay people, could think that we are doing something wrongly because we don't know what does it mean, because he does organ donation on that patient and you keep a patient alive. So there is a lot of discussion, and I think we spend decades for demonstrating that we are different. We watch the other way around. We try to find which is the minimum determinants for defining brain death. Sarah was saying, Harvard was suggesting to have EEG. EEG is still mandatory in Italy and in other European countries. So it's something that is not needed in the USA, but it's needed in the, as ancillary test could be done, but in some states it's needed. So you need to think about the variability, because it's not due to doctors, but also to law, to ethical region, to religion and so on, to be sure. But at the end, if you squeeze the principle in brain death project, you return back to a couple of principles, and they are everywhere, constant. So the main message is, even if we do things differently, think about the observation time for declaring a patient dead. There is no rule. Sometimes it's 6 hours. There is some article that say you can do 2 examinations in New York very shortly and you declare a patient dead. In Italy, you need to wait a certain time. So there are differences, but the main concepts are worldwide. So I think it's the first important message in the history, that we did think differently, but at the end of the day, the principles are, let's say, accepted everywhere. And the World Brain Death Project, if you take a look at it, it's on the JAMA, is open access. There is written which are the minimum standard for declaring a patient death.
Yeah. Any questions so far? Jump in. And some of the areas, challenges, and also areas of variations. As Dr. Citerio hinted, they happen in many different stages. And I always think about brain death in several buckets. And I think the first one is just determining that you can even do it. And how many of you would declare brain death or do it in their clinical practice or have done it? And so, you know, it's a very time-intense process. It's emotionally challenging for the families, for you, for the nurses, for everyone. And it takes a lot of time. Sometimes you have an ICU of 20 patients, and that is the patient that takes the longest time. And so usually, you know, before you even start determining whether it's appropriate, we have a large statewide donation organization that oversees 64 hospitals. And they have to, per law, after a patient is declared, they have to review it. And so we actually partnered with them to look at their reviews. And the most common kind of practice deviation or problem is right here up front, that someone misses something and starts declaring when they shouldn't. So it's very interesting. So you think about that, coupled with the time. And then you think about the clinical exam, the apnea test, ancillary testing. And then I think a really key part of the care is also communication, because as you do this, in many steps, you have to communicate with the family, with your team, and then at some point with the organ procurement organization, if that is a question.
Do you want to enter in some of this point, or you enter in
Sorry?
later on? Do you want to discuss some of this point, or do you want to enter in this point later?
I'll jump. We have a few cases that kind of highlight all of these.
Okay, perfect.
So let's do learning by doing. But did you want to add anything to that? Any
learning by doing.
Points? All right, let's start. And please participate. It's late in the day and we're all a little sleepy, and let's jump in. So this is a 39-year-old man, medical cardiac ICU admission, was found down in PA arrest, and after 6 rounds had return of spontaneous circulation. Those are his vital signs. His urine drug screen is positive, and there were actually some pill bottles found next to him. And, you know, as every cardiac arrest placed on TTMs has a lot of movements and jerks, and started on levetiracetam and lacosamide. You know, for the TTM, get some sedation, and then has a head CT that shows sulcal effacement. At some point, he's rewarmed, and the nurses notice that he has no brainstem reflexes and calls the clinical team. And, you know, you're getting paged. It's 2 a.m. What do you want to know? What are your next steps?
Are you paged on the same day of the arrival of a patient or the day after?
You get, well, he's been on TTM and rewarmed, so it must be the hospital day
2 days.
2.5.
2 days. Okay.
2.5.
So which are your comments on this case?
This looks like a very sad case.
Please, sorry.
This looks like a very sad case. 39-year-old who we've cooled for 24 hours and allowed to rewarm, and then we need to assess the reflexes. Obviously, my thoughts would be, what is the primary cause? And it sounds like a hypoxic event, unfortunately, hypoxic encephalopathy. Is there anything we've done to the patient that is causing them to have no brainstem reflexes? Any drugs? Any, you know, think about the temperature. Any predisposing medications or diseases that the patient may have that's caused a problem. Any such euthanasia or such. So looking at things that may be causing the lack of reflexes before we go on to examine the reflexes.
Which are your idea on the possible cause? Because CT on the head said that there is sulcal effacement, there is brain edema, evidence of herniation. So we have a damage due to the cardiac arrest. Yes. So which are the confounders here that you can see in this case?
Does he have a sedation? Maybe
so it was on sedation, and that's excellent. I didn't put it here because I wanted to see who asked, and you did it. So during the TTM, there was shivering, and and there were these movements because he was twitching. There was concern for seizure. There was a propofol and fentanyl infusion started briefly.
That's the why he doesn't respond.
Nice. Yes, absolutely. And you already started.
How long do you wait if he has been sedated after TTM? They suspend the TTM. So it was on temperature control for 3 days. He was under drugs, maybe propofol. I don't know which drugs he was using, propofol. And
I withdraw the sedation.
By now it's withdrawn, but let's say the day before it was on. During the TTM it was on, and then when they noticed the reflexes, they stopped it.
Sorry, TTM is?
Targeted temperature management. So because of the cardiac arrest, they tried to keep the temperature initially low. And then with that, there's shivering. So, They did 35. Let's say they read the threads.
3 days?
Yeah. It was 35, but let's say his temperature coming in when he was found down was 33, because he was found down in the outside.
Any idea about the temperature and drugs?
Any idea, but what was
About the relationship between the infusion of the drugs and the temperature?
it slows the metabolism of the drugs, so you have to wait longer.
There are some cases in which the patient that go lower, 32 degrees, has some reflexes after days of the suspension of the drugs. And also it depends about the function of the hepatic function and the renal function, please.
Yeah.
Maybe some study to check the flujo, the flux, like a Doppler or something.
That's very smart. We'll get to that. I
Yeah.
think you're hinting at transcranial Doppler, which is an ancillary study. And so you're absolutely right. And I think you guys all got it that. And we made this particularly, cardiac arrest, the hypothermic. He already took a bunch of fentanyl. He was on sedation. He was hypothermic. He probably has a little bit of shock liver and shock kidney. So I think this is a case where you're really worried about confounders in many ways. And the question is always how long to wait. And then the number one thing is when I get called from the nurses saying, come declare brain death, you look at the chart. Like so oftentimes as a team told me, like they're off sedation, you can come and declare them. And then you look at the chart, you open it. I usually also sometimes send a tox screen when in doubt. I think in this one, that's very tricky. And you're right. It's probably a situation where at some point you head to an ancillary test if you can't tell for sure. But I do think, you wait for time to get the drugs out of the system. I find it very hard in cardiac arrest when there's an infusion and then also in decreased metabolization of the medications. What do you do?
I was thinking about your suggestion, but it's a wise suggestion. We use repeated TCD in understanding when the flow became reverberant. But in Italy, you can certificate brain death also that way, but there is no certification for being certificate for doing that. So we use it as a screening criteria. Mainly when, for example, the ICP is not a case of ICP. When ICP goes very high, we repeat the Doppler and we see the moment in which we are not able to save the patient and the flow became reverberant. At that stage, if a patient does any intoxication, you need to do some cerebral blood flow test.
Yeah.
Angiosity, angiography, whatever you want. But I think I use it like a sensitivity exam bedside for understanding if, for example, the drugs are still high, I cannot do the evaluation for brainstem reflexes, and I'm not sure, I do a perfusion test at that time.
This might be because of legislation, but why would you want to declare this patient? First, it's just neuroprognostication, and declaration of brain death is only necessary in case of donation. So why don't we just neuroprognosticate instead of declaring? Because you said if they call me in the middle of the night, do you want to declare the patient? Then I say you can wait till tomorrow in the morning.
That's an excellent point. It's a really good question. And so first of all, actually, I said purposefully, provocatively at 2 a.m. because we also often, our residents get these calls at 2 a.m. and who really needs to declare brain death at 2 a.m. anyway? Like from a family standpoint, like, are you going to call the family and tell them, oh, we think your loved one's dead? Like, does it have to be at 2 a.m.? And our nurses always get really, they're like, come now, see the patient because they're very hemodynamically unstable. But the worst thing that can happen is the patient will crash from a cardiac standpoint. That's sometimes not the worst for the family. But so I agree, don't rush into it. I do think if there's, in the daylight after removing confounders, if there's really concern for brain death, I wouldn't necessarily go down the whole SSCP, biomarkers route necessarily. But you're right. First, I would just take a step back and just look at all the data and wait and do some prognostication. I put purposefully in there that this head CT, that there's no clear evidence of herniation. So there's effacement, it looks bad. Sometimes, you have the proximate cause has to be in CT, and often the CT looks bad. And so you're like, it looks bad, I'll do it. But I think sometimes if you look closely, you do want to see herniation. You want to make sure it's not just P fossa. And I've definitely seen scans that look very swollen in young people, but they were actually, the gray-white is very unreliable early on. So actually, before I would do anything this patient, if there's a change, I would probably repeat the scan to see if it's really bad. If there's no clear reason, you wouldn't do it.
Another reason in certain countries that you need to declare, like in our country, we can...
Where are you from?
I'm Dutch, so Holland. So
Yes.
we don't
Okay.
need declaration of brain death to
Yeah.
withdraw life-sustaining therapy. So I'm just
That's
wondering
interesting.
if there are countries that it is necessary.
I would love to hear from the group. I can tell you about where I practice. But yeah, any other? Do you need to declare?
No,
Yeah.
We would be saying that we would. Thank you. We would very much prognosticate, and then if there was likelihood that the patient could donate, we would start thinking along those lines. But yeah,
Yeah.
if the organ donation wasn't an option, we would just prognosticate as normally.
Yeah. Yeah. It's a very good question.
the idea of keeping the two-stage separate is mandatory.
Yeah.
So you need to take care of the patient till the patient could be alive. Today, this morning in the opening ceremony, we discussed a lot. We discussed a lot in the conference we had over the weekend about the difficulties we have to have an early prognostication. Sometimes we are uncertain, and looking at difference between the countries. Some countries are yours, probably are more prone to stop. It's real. To stop the treatment, probably the same patient in my country will have a full treatment for a longer period, and we will take a look. But our difference we need to understand and to think about. But you are right that at this stage, probably the question of the resident, which are the next step, not the organ donation, because you say what to do next, because the patient is losing reflexes, the patient is normothermic, patient no brainstem reflexes, and they ask Sarah what to do. And one option could be also evaluation organ donation, but I think it's their own time, as we say. But it's not the question now if we are discussing about organ donation.
And it's so interesting that you asked about country level variation. And we actually published a study about 10 years ago where we looked at 93 countries, and just like the variations in practices mainly, with Elcovedics. But one thing we found is when we looked at low-income countries and countries that didn't have an organ transplant network, that was far less associated with having a legal provision. And so the two are somewhat linked because there is one way that leads to donation, but there were strong associations between the presence of the donor transplant network and legal provisions and institutional protocols. That being said, I absolutely agree that from our perspective, our responsibility to the patients is not to think about that first, it's separate. In the US, actually, and there have been laws that have changed, but for example, so you don't have to declare if you think it's catastrophic, the family understands it, and say the patient doesn't want it. In younger patients, my experience, often the family sometimes wants it or doesn't want to accept it, so you also would do it for the family, or in children especially, our pediatric neurointensivists tell us. I would say though, if sometimes we have an 80-year-old, clearly herniated families, like, they're demented, they wouldn't want to live like this, like you don't have to. We though have a rule, a legal rule in our state, in the US every state is different, but that we have to at least let the organ procurement donation know, like we can't just do it. We actually get dinged from the hospital administration and there's a financial incentive, but we have to let them know and then separately give them the chance to approach. They would then respect the wish of the family. But it's a bit of a complicated, and some of us actually feel ethically conflicted about it, so it's, yeah. Hey. Okay, let's say we repeat the CT and he is completely herniated and the drug screen, we've waited, there's this waiting for half-lives, but, his labs actually look okay, and he's rewarmed, no reflexes. Would you proceed with a clinical examination at this point? No? Let's say you've waited another 2 days. There's no sedation. The temperature's been okay. Temperature.
Now,
How long?
for us, it starts again. Do you consider donation? If you don't consider donation, then you can just do the prognostication. And if it's devastating brain injury, then we call the organ if they are registered.
Yeah.
And if it's a no, then it's done.
Yeah.
And otherwise, we will proceed to declaring of brain death.
Yeah.
But otherwise, we won't.
Is it based on the registration or based on the family or both?
The registration of the patient is first. So if he has a yes, or we have opt-out system now since a few years. So everybody is a yes if they don't have anything in there.
Yeah.
And otherwise, they can also choose to have the family decide or put in no. But the what's in the register is above the family wishes. And that does sometimes give some moral distress, so we sometimes violate it to prevent grieving problems.
Yeah. It is actually the same for us, and there's many of us that have actually unregistered. They've said, I still want to be a donor, but I want my family to have the say. But you're right, and legally, again, in my setting, it is that if you have registered, that means that trumps the family's wish when a patient's declared. But yeah, it's similar. Okay, let's say the family, usually we don't bring it upstairs, also is interested in donation. He's registered. Yeah. Oh, yeah.
So I'm one of the registrars in the UK. We have a sort of training program run by the National Organ Donation to try and equip us to move forward with this. And actually, this question came up there about patient wishes versus family wishes / expectation. And we were challenged with the question about what do you do if the family say no and the patient says yes? And I don't know if it's different in the US or in Italy, but nobody's challenged that yes in the UK. So.
Yeah, so technically it is, by the law, it is the patient's wish trumps the family wishes, if they're really brain dead. If it's DCD and they're not just very brain damaged, it's not. Again, we always feel conflicted, and then everyone, including the organ donation team, tries to make this a good situation for the family. So they don't tell them, you don't get a say. I would say realistically it depends, because if this is a 70-year-old with bad liver with on dialysis, the organ donation people won't fight it. If it's a very young patient with good organs, they actually go to the Attorney General while they give the family time. And just, I've never seen it come to a lawsuit, but there's been situations where it's been tense. What I will say is we often kind of navigate it with the family and give it a little time. And then sometimes if there's strong cultural or religious regions, they actually accept it and walk away. But it's a dicey one. Yeah. Oh, well.
I think if you look at what has been discussed earlier, the wishes of the patient comes first.
Yeah.
And so when we discuss with the family, there is some disagreement, someone in the family saying, what are you doing? Because we return back to the first point. Sometimes they are not certain about the diagnosis. So I said there is a standard everywhere, even if the law are different. And you need to stress that. And what is not being touched by Sarah till now, the patient arrived to a declaration or a status of brain death, not in a second, but is a path in which you start to discuss with the family, is losing reflex, is not responding to therapy. Today, look, the patient is the same, but is much worse than yesterday because A, B, C, D are worsening. Now he's not able to breathe. So if I switch off the ventilator, he's going to die. But he will not recover because there is a path that describes the history of the patient. And at that stage, the willness of the patient comes first. I know there are some conflicts. I discussed with the family since the 90s, so I know it doesn't matter what was the issue. But the family, most of the family, we should start saying, is what he wanted or she wanted. We need to respect her or him. At the end, even if the religion is different, if they have different opinion, at the end, they accept the willingness of the patient. Sometimes it's the signal that something in the process of communication did wrong before this discussion. A mistrust about the keep, a mistrust about some decision that has not been accepted by the family and so on, surgery not done, for example, and then you ask for organs donation and they are upset. So there is a lot of issue, but I think what Sarah said, if you return back to the basic, the patient is losing reflexes, is going to die, is dead by me, by my clinical examination, and you want to do that. So you are not respecting him or her. So the situation becomes, I think, more tricky. You need to maybe discuss more than one, but at the end, we never had problem in this set. And we do roughly 35 organ donation in my unit every year, and we have also a DCD program. So we see the situation. We discuss often this kind of problem.
Yeah, for sure. And there's always, you tapped right into the ethical dilemmas. But we had a patient, for example, who was illiterate, where the family was like, well, could he read when he went to the driver's license? Or we had someone that was just, constantly an addict. And they were like, he probably didn't even. So sometimes there's these situations too. But yeah, no, it's a dicey one. And I think it's very case by case. Okay, moving forward, I want to make sure we get through everything. Let's say,
We are on the same
you've
line.
waited
Okay.
for a long time. Actually, one thing, how long would you wait with regards to the temperature? What are your where do you want the temperature to be? Because that's another big one. For how long? And I'm actually going to quickly advance slides to a case at the very end, just to show you.
You put together more than one case?
Yeah, I'll go to your case for a moment. We have a lot of slides. We won't get through all of them. We just wanted material, but this one. Sorry. So it's this one.
This has been published.
This is a case that was published in Critical Care Medicine by the Emory Group. But this is a case that came in and was basically found down and was hypothermic, I think initially to the low 34s, 35s, and got therapeutic hypothermia. And 48 hours basically after losing neurologic function, the exam was consistent with brain death. And then basically went to the OR, and there were basically concerns about, is that this one, Giuseppe? Wait. No, this one. So this was a case that came in super hypothermic to the 33s.
At the end, the patient did recover some reflexes.
Sorry, we'll just go back,
but I think returning back of what she suggested.
Yeah.
If you have any doubt, looking at the flow is a key element. Because if a patient is going to die, you face a situation in which the cerebral flow is not present. And then you are almost sure that the apnea or the other positive test, loss of the reflexes and so on, are due to the reduction of cerebral flow inside the scala. And she put also a point before, because there is UK people, there is European people. At the beginning you say brainstem death or wall vessel brainstem death, brain death. I think there is no difference, except the way you are testing. Because I like the idea of the UK people, because I think the UK historically, because Sarah say, is a subproduct of intensive care. What was changing in the Muller paper in 1958? He saw some patient with a ventilator that substitute ventilation and the brainstem was not working. He was surprised that the patient was alive. So the loss of ventilation of the respiratory trigger is what makes the patient die, because he's not able to breathe, even if he or she has some cortical activity. In some other count, because after 5 minutes, 10 minutes, everything will be lost if he's not able to breathe. In some countries, or my country and other countries, we want to have both a brainstem death plus a cortical death. Sometimes the timing is not the same, because we need to have intracranial hypertension, we need to have a reduction of the blood flow, and in our setting, we need to have both situations at the same time present for declaring a patient death. But from my point of view, the patient you declare death with some electrical activity, with the brainstem not working, is going to die in minutes. So for me, it's the same situation. So there has been a lot of discussion about these two criteria, but at the end, if you look which are the principle, and I invite you to return back to the JAMA paper, the Word project, you see what's the element.
Yeah, I think one part where it becomes an issue, there's the case that we had that with PFOS bleeds and injuries, because those can mimic brain death, but just be locked in and have cortical function. And that's sometimes so it's worth looking, although oftentimes these patients do develop hydrocephalus and eventually do become brain death. But yeah, Dr. Citerio, what do you do when you have profound PFOS injury? What's your approach?
We had a couple of cases recently in which my colleague was surprised of the idea of testing VEG in this setting.
Yeah.
If you look at the cortical activity, you discover immediately the patient have a locked-in syndrome. It's not so frequent. You need to think about, if you look at the lesion at the CT scan, if you have basilar artery occlusion, you need to keep in mind that this could happen.
Yeah.
And the patient could be thought as a brain deaf,
Yeah.
but for example, in my country, we need to have EEG for saying brain deaf. Probably in UK could happen. And if you have any doubt, we discussed today in the morning of the round table, say you need to make additional exam where you have any doubt.
Yeah.
And electrophysiology is very simple, even if it's not mandatory for law. But if you have a doubt, if this patient could have a normal cortical activity, having an EEG is a very simple maneuver, test, and you have an answer immediately. So I think in any doubt, do an EEG.
Yeah, I fully agree, and I'm glad you said it. With us right now, we had this new AAN guidelines where they said EEG is no longer an acceptable ancillary test.
There is something
And
else at 4
that's caused a
o'clock,
lot
yeah?
of
Another
ruffles
speaker at 4
because
o'clock?
it's a good bedside test. You don't always want your super unstable patient on
is
3
another one
stressors
at
to go to the
4
nuke med scanner. The reason they said that is because the confounders, and usually the reason of an ancillary test is that you're worried about metabolic sedation and hypothermia, and it's prone to all of these. And then also the EEG is set at such sensitive filters that you can get vent artifact and things that then get you into trouble. I do think it's exactly that case where we're worried about cortical function. And I think this is different than the brainstem death. I agree, are kind of the same concept. But in this one, this could have totally normal cortical activities. So I would slap on an EEG right away. And then maybe also down the road get more ancillary testing, like a perfusion scan.
Usually this kind of patient return back to have some respiratory effort, not immediately, after some days. And so you need to wait. But if you have a cortical activity, you have to wait. Sarah, it's 4 o'clock. I think we can go ahead till 5 o'clock. I don't know which is the end, but I don't know. Someone else is coming here? Because Sarah said to me, with 2 slides, I can stay for hours.
4:15. I think we have till 4:15.
Okay, 4:15, perfect.
Minutes,
Oh, wonderful.
In terms of temperature, now I jumped to the wrong case, but Dr. Citerio put the slides in of that case in critical care medicine that came in profoundly hypothermic and actually was warm for 48 hours and declared, and then I think in the OR gagged or regained the cough reflex. And so they published that case report. The new guidelines, I think, say that you should be normothermic for at least 24 hours and over 36. That being said, I think if someone comes in normothermic and then in your hospital on your watch, like dips to 35 point something for 10 minutes, that's maybe not a huge confounder. And they have 15 bullets through their head and a clear proximate cause. I think if someone's found down in the snow and comes in, we had one patient that came in at 29 in mixed edema coma. And actually, day 6, we did TCDs and they still actually had flow. And at some point, they progressed. But so I do think it depends a little bit also on the clinical circumstances. But for sure, it does push you to wait a little and then also get confirmatory tests, for sure.
One point we say always when we write guidelines and also in the project, the diagnosis is clinical. By other sentence, if you have any doubt, do some extra test. What? And time, for sure. We discussed already about time. So you need to keep your time in this case, for example.
Yeah.
You don't need to rush. But if you still have any doubt, please do an additional test. Maybe TCD, maybe EEG, maybe whatever you want. But you confirm your diagnosis, at least. You say, I'm sure.
Yeah.
EEG, it's no...
EEG with the reduction of the temperature could be influenced but also by the drugs and the reduction of the temperature. So your suggestion to do a TCD in this case, I think is wise.
Yes, because in this case you can do an EEG. Why? Because the EEG only check the but in this patient you can check the clinical reflexes. Mm-hmm. So,
are there any pediatricians? Oh, sorry, I didn't mean to interrupt.
No, the suggestion when you are not able to test all the reflexes, for example, the patient has an eye trauma, or you cannot explore the eye, or other reason, if you test the apnea, we start the apnea test, is not able to afford the apnea test because the saturation goes down, it's mandatory to do a cerebral blood flow determination and an EEG. If you have any doubt and you cannot do the exploration of the brainstem, it's mandatory to do that. Because, for example, if you disconnect the ventilator, we usually use PEEP always connected to the tube, 5 centimeter of water or PEEP, a little bit of oxygen, we keep apnea. And if the patient goes down with saturation, we cannot afford it, we do a evaluation of a cerebral blood flow.
Yeah, completely true. Yeah. Are there any pediatricians here in this group? Yeah, any pediatricians? And some pediatricians, and based on surveys and protocols, there's many more exams and ancillary tests. And, some pediatricians say kids metabolize differently, but I think a big part of this is also with the waiting time. Sometimes it's not, you don't want to wait for 6 days and someone that's clearly, at some point there's also resource utilization and it's not good on the family. But actually, I never utter the words brain death in the ED. I also tell my residents, never even mention it. I feel like the first bond with the family is that you just, show them that you're sorry and show the concern that this is very bad. But I do think it takes time for the family. For us, 2 days is not a lot. For a family, young patient, is a shocking thing. It is a lot to cope with that. So I think sometimes just giving a day of time and then planning the ancillary test, setting yourself up, also sets the family up for then not suddenly saying, wait a minute, I don't want you to take him off the vent. I'm going to go to the lawyers. And so I think it's actually good to just also make it, supportive.
We tend to use 4-vessel digital angiography.
You do?
Yeah,
Oh.
as our ancillary tests, we
You
would.
do it? Yeah.
And we find that's very useful to show to the family.
Yeah.
Because you can demonstrate
It's
such a difference
zero.
between
Yeah.
normal
Yeah.
and the four-vessel angiography where
Yeah.
you're missing out.
Yeah. It's amazing. I've only seen that twice, and it was twice, and someone that had an ambiguous nuke-med scan, and then one was a kid with an open fontanelle, and the other one was someone that had a gunshot wound where it was cranied, where we thought the TCDs and the nuke-med might not be reliable. For us, it's a huge challenge to get it, just because it's transporting a patient, a procedure, getting the OR, and so it's easier to just get a scan. But do you do 4-vessel angio, or have you? Yeah.
Or
yeah,
angio
I've seen them
CT.
yeah.
Angio CT,
yeah.
well done, give the same information. There is a lot of discussion
Yeah,
because
CT.
it's not documented like the
Yeah.
angiography, but it's much easier. If you look in angio CT, my suggestion is to take a look at the extracranial vessel.
Yeah.
Because you have a stop here,
Yeah.
and the catheter is siphon, and there is no flow coming inside the skull, but you need to have contrast on the external carotid, because you can say, I see that the time spent waiting, the contrast coming is enough to see that externally you have a flow, but you have a stop here. And so if you show to the family, for example, if you did the exam 2 or 3 days ago with a flow, and say, there is no more flow coming inside, I think there is no discussion, understanding whether the patient is brain deaf. Even if you have some conflict with the family, you want to demonstrate that the situation is that way. I follow the suggestion of a colleague there to do the TCD, because it's much easier. Sometimes we go to do an angio, CT, and then there is a residual flow, you have to return back the day after. So we want to go there, sure, where there is no flow. And the exam gives us a clear documentation that could be put in the chart, very well described, with a protocol done, and so it's perfect, and say there is no flow inside the skull.
Yeah.
And I use this approach because in the past we did many angio CT with some residual flow, and we became crazy.
Yeah.
And also to the family, you have to say there is some residual flow. For me, it's not important, but there is some flow, so I need to wait.
Yeah.
Yeah.
And the CTA, I really like it. And oftentimes our patients get it anyway as the part of the initial. That being said, it's never the only ancillary test based on which I declare. But it's just good to get a look. And actually, conversely, there was, for example, a family that was very, upset. There were lots of emotions where we got the CTA and we saw flow, and then we actually didn't proceed with the exam. But where we were kind of, not fully sure what was happening with that patient. But it's definitely helpful. There's a group that I collaborate with that's now doing a study where they're doing a CTA right next to an angio, or because oftentimes the CTA happens early, but to see how they correlate. Because it's not 100% sensitive based on studies, but that may be because it's often done earlier. And so, that's an interesting question. But okay, so let's say he's been off sedation, his tox screen is negative, he's been rewarmed for 72 hours, past the TTM, and you do a first exam, but then his oxygenation gets worse, and he does this, PDF ratio 150. What do you do with this patient?
PP is already 12, FiO2 is 80 in your case. A bad situation.
Yes, yeah. So it's one of the questions. Yeah.
So then it would mean ancillary tests
Yes.
going forward. whether they are nucleotide, full vessel angiography, EEG, etc.
Yeah, definitely. I mean, there's two components, right? You want the ABG to be the PCO2 to be in a range where it's appropriate, just so you can measure the rise. But then there's also the question: is it safe, right? And
what about the increase of CO2?
Sorry, the CO2 is more to, like, you want to titrate the ventilator to have it in a certain range. That's the prerequisite. But that's more to make sure you're measuring the right delta. Or in the COPD, you want to make sure it's close to baseline. In this case, like, you want to make sure it's not unsafe, right? And I think this is very obviously not safe. Just weird ethical question: how aggressive would you treat this? Would you prone the patient, or do a few diuresis, or do you add a few presses?
As you would.
Yeah.
So I would do what I would normally do, but I would be organising the tests as well, because again, for the family and the patient, keeping them alive may not be in their best interests, and so you want to get the information to get them where they need to be eventually, and the family.
Correct. Excellent. Mm-hmm. Yeah. Huh? Sorry. Yeah, the sedation, the toxicology is negative. Like, this is just hypothetically. Okay. Let's see, we have 3 more minutes. Do you guys want to speak about specific questions, or maybe
I think we can answer a question in 2 minutes if they have
questions out.
They could challenge you.
Yeah, because we already covered a lot of things.
Do we need to close? Now?
No? Yeah.
Immediately? Okay, one question.
Okay.
Then we will close.
Last question. Or you can tell us what's wrong with this one.
2 minutes, okay, we are leaving, okay. What's the question, Sarah?
Yeah, I'm just saying, what's the problem with this one? What? Sorry? The blood pressure, yes. So let's say, everything, all of this looks good. Car accident, bad subdural is herniated, right? No sedation. But yes, so the blood pressure, there's a prerequisite. And
no surgery here?
And then,
No surgery?
Let's see, surgery isn't offered. And I haven't actually shown, this is another scan where you want to scroll down to the level of the brainstem. Sorry? Shock. Sedation, shock, yeah. So the shock, it could be, it's tricky, it's a trauma, they could be bleeding. So, as you said, you still work them up for etiologies, reverse them. It's also in young patients, you can see Takotsubo and cardiogenic myopathy, and you can see DI. And so definitely, I think you do have to do your shock assessment. Does that mean you can declare this patient? And then I think we have to stop. So for hypotension, you can, if you can fix it with presses, but they have to be higher than 100, and the MAP has to be higher than 75 during the exam. And I always put in an A-line. Now you have to do it for the apnea testing, but I always put in an A-line before, because I've definitely done the test, and I've done, the reflexes, and I turn around, and the blood pressure cuff has cycled, and, the blood pressure jumps. So I usually titrate the presses, so it's well above the threshold. So there's one more problem with this patient, though. Let's see who can catch it. Let's say, no sedation, no temperature, the scan's horrible, then organ donor, you've waited for a very long time. Yeah. And we do a sim lab with our fellows. We sometimes put a C-collar on the mannequin, and we don't say anything. We just run through the sim, and at some point we're like, what about this? So, yeah.
I think we need to finish.
Yeah. Okay, wonderful.
Thank you.
This is fun.